To this session on cataract panorama. It's going to be a highly interactive, practically oriented session. Basically, just a series of videos, and we have a very distinguished set of panelists who will be taking you through how to manage each and every situation. Interaction is always welcome. Any inputs from each of you would be most appropriate. And before we start with the session, we have a wonderful guest talk given by none other than Dr. Sartaj Grewal. He's basically from Chandigarh, but now well settled in Northwestern University in US and specialist in cataract and refractive surgery. And he's going to be talking to us about enhancing efficiency and outcomes with digital outflow solutions in cataract surgery. He's widely published and becoming more and more in the recent past. Over to you, Sartaj.
Thank you so much, sir. So I'd like to thank the scientific committee for giving me this opportunity today. So I'd just like to discuss briefly about a topic that is very closely linked to cataract surgery, but it is something that we tend to overlook most of the time. And that is the whole process, the whole experience, especially from a patient's perspective. And in that, what I've highlighted over here is efficiency and outcomes. Both of these things have to go hand in hand. Very good outcomes, but where the patient experience involved a lot of waiting time or maybe some errors will not be positive overall. So we really need to look at this overall picture. I am a consultant for Carl Zeiss. So what is the traditional sort of path or workflow that we have in our practices right now? That would basically be that we first examine the patient, identify the patient has a cataract, send them for a biometry. Then the patient would undergo a counseling. Then the patient would probably come back to us. We would discuss the IOL options that they have narrowed down after the counseling. We would then maybe ask for new biometry printouts based on the lens that the patient has finally actually selected. Then we would contact the company or our own stock and confirm whether the IOL availability is there. Then accordingly, we would have to schedule the surgery. Then on the day of surgery, depending what we are using the OR, we'd have to retrieve again the relevant data for that patient. Confirm the data, do a timeout in the OT itself. And even after all this is done, once we have all this data, what do we even do with it? It's not very easy to access, to optimize our results or to conduct any kind of research on this. So these are the limitations that we have with convention. That there is a lot of redundancy. There are chances of errors, especially transcription errors. These could be a very easy to miss cause of an IOL surprise. The more times you have to enter this data in different areas, there are again more chances of errors, there is more time that is being consumed. What is also very important is that healthcare delivery is experiential for the patient. As technology is evolving, when patients can just open up an app on their phone, order food, or order a grocery item that is delivered in 10 minutes, patients expect similar outcomes or similar experience in healthcare also. For us, healthcare is that, no, this is different. But patients don't want it to be different. Patients want it to be as fast, as efficient as anything else in their lives. And if you talk to patients, usually their biggest gripe is waiting time or how much time they have to spend in a hospital. Many times this could just be a reason for them to delay the whole cataract surgery process. So we have wonderful digital operating tools that are available to help us address this to a large extent. This is an ecosystem. So this is an ecosystem where you can capture data from the patients, process this data, and then actually utilize this data during the treatment process. So basically, your data will be in the cloud. It's very easy. You can access this from anywhere, on your phone, in the clinic, at home, on the computer if you want to go over your list for the next day, look at all the patient parameters. You can easily edit anything without having to actually leave your clinic OPD and go to the biometry room. You can do all that from your own clinic, your own chamber. It's great for researchers because, again, you can access and retrieve this data no matter where you are. So let's just talk about toric IOLs. The conventional workflow involves at least 6 steps for planning surgery and executing surgery. But when you incorporate surgical tools, digital surgical tools, this can actually be narrowed down to just 3 steps. And there are numerous studies that have been done, including this one by NICE in NHS, which was on 120 eyes undergoing toric IOLs. And they actually showed that they saved almost 6 minutes per eye in the whole preoperative planning process. And overall, including the whole process of data importing in the OT and all, that even increased to 6.5 minutes. What is important is we tend to overlook the fact that, or we tend to sort of avoid these technologies on the base of any kind of upfront or recurring cost. But what is interesting is that you can actually save about 35% of your cost when performing these procedures, largely because of reduction in manpower needs, largely because of reduction in various errors that can happen. Another study showed, again, 6.5 minutes or a 34.4% reduction in time. The more time you save, the more patients you can see, the more patients you can operate upon. That, again, will directly affect your revenue. So it is important to understand that you will not see a very direct correlation in terms of increased output when you incorporate these, but over time, it really adds up and it pays for itself. Another study that was conducted over here in India itself, in Bangalore and Hyderabad, again, these were just on conventional monofocal IOLs. And they showed, again, 6.5 minutes saved per patient, even the variability in time, because some patients might end up spending a lot of time, some patients it might be faster. That variability was reduced by 3 times. And the number of data entry points that had to be done by the staff reduced by 47%, and the number of staff that was required itself reduced by about 30%. For us, it is staffing people, recruiting people, keeping them happy, training them is a big burden for almost any practitioner. And if we are able to reduce that by 30%, that is incredible. Again, this was a large study that was done in Germany. This showed 14 minutes saved for a toric IOL patient, 10 minutes for your other premium IOLs, and 7.5 minutes for any patient undergoing a monofocal IOL. These are tremendous savings that can really, again, help us do more for our patients. The other important thing, other than just efficiency, is also outcomes. And there are certain never events that can happen, errors that happen because of transcription errors in entering data at different points. And using digital technology like this, again, NICE in the UK showed that we can really reduce the occurrence of such never events. And it's usually the communication handover from one point to the other where you can have errors. And if you can reduce this with such technology, it really helps. So the advantages, again, are you save time, you have the convenience of doing these calculations remotely anywhere. It can help you reduce your staffing requirement in your practice. And in the future, we have newer platforms from various companies, such as Veracity, which have even better AI algorithms to help us improve our power calculation to optimize our A constants postoperatively. And you also have platforms coming up, such as Surgery Optimizer, where you can review your videos very conveniently and help refine the different steps that you have during surgery. So limitations cost, but this is not a true limitation. If you look at the larger picture, you will actually end up saving in the long run. But yes, there is vulnerability in technology to server downtime. And yes, if you invest in this, you would be confined to one ecosystem. So again, but I will strongly recommend this is the future. Our patients deserve this. We need to transition to this. And again, to help save time, errors, and better outcomes and experiences for our patients. Thank you.
Thank you so much, Dr. Shataj, for that wonderful keynote address. Now we'll come to our session on Cataract Panorama. As I mentioned during my introduction, it's going to be a series of interactive presentations. I'll be showing some of the problems, challenges that we face during routine cataract surgery. It's nothing that you or me cannot do on a day-to-day basis. It's simple problems that we face and how we handle them. I have a stellar list of panelists with me, Dr. David Chang, Dr. Douglas Koch. Both of them will be here in another 10 minutes' time. And our own stalwarts, Dr. Amar Agarwal, Dr. Chitra Ramamurthy, Dr. Mahipal Sachdev, Dr. Tetial, Dr. Rohit Om Prakash. He'll also be coming in shortly, and Shresh. So let me start off with my first case, and the person who introduced this concept of scaffolding is right here, Dr. Amar Agarwal. Of course, now we are using it for various different purposes. And this is just to show you a case where there is a Morgagnonian cataract. As you know, these cases, the moment you do a small puncture, immediately the viscoelastic, not able to stop this video. Pause करने का है क्या? So the moment you pause हो सकता है क्या? नहीं, यहाँ पे मेरे so I'm sorry about that. नहीं, वो पॉज यही नहीं आ रहा है, कर्सर नहीं आ रहा है। नहीं, पॉज करना है। हाँ, वो नीचे एक लाइन आएगा ना,
स्लाइड शो को हटाना पड़ेगा। स्लाइड शो भी कर रखा है आपने, उसको चेंज करिए।
क्या करें?
स्पेस बटन टू पॉज एंड स्पेस टू स्टार्ट अगेन, दैट्स इनफ। स्पेस से नहीं होगा क्योंकि इनका वो उसमें चल रहा है प्रेजेंटर मोड में। प्रेजेंटर मोड को हटाना पड़ेगा, तो प्ले कीजिए यहाँ से, चेंज हो जाएगा कंट्रोल्स। प्रेजेंटर मोड सेटिंग कहाँ से आएगा इसमें? सेटिंग्स
नहीं होगा। ठीक है, okay, great. Thank you. So as you see here, sorry about that disruption. This is a total cataract, a Morgangian cataract. In these cases, obviously, capsulorhexis is not the issue, but it has a hard nut of a nucleus inside, and because once you make a small puncture, the milky fluid just flows out, and it's not a significant upthrust that you have. And when you have a large nucleus like this, which is fairly hard to crack and which rolls around, and you can get, it's a little difficult to get a grasp on this. Any tips that you will observe to deal with this case? Dr. Tityal, would you like to start?
Yeah, thank you, Ram. I think that these cases sometimes can be challenging because this nucleus keeps floating, and difficult to hold it, to crack it or chop it. So sometimes if nucleus is not too small, or what I do normally, I put, viscoelastic underneath that to get the, bag inflated, and that will also stabilize the nucleus in a way. Then go with the, in the central area, get your phaco tip into the matrix of this cataract, pull little bit, you can reach up to the periphery, then crack the nucleus into halves. That can be possible.
This is exactly what I used to do, in the sense that, protecting the posterior capsule by inflating the bag as much as possible.
Yep.
With a preferably a dispersive viscoelastic,
Yes.
because the cohesive will flow out, and you want the capsule bag to be inflated. Any ideas, Amar? I mean, would you do a...
I think IOL scaffold, as you mentioned on the top, is the best for this, because these are Morgangian cataracts. As Ram is putting beautifully a IOL inside, even though there is no PC rupture, he's created a posterior capsule of his own. So that's very sturdy. So now whatever happens, even if surge happens now, let's give an example, nothing will happen, because the capsule is supported by the IOL scaffold, which is another capsule. Actually, you have created a secondary, your own capsule. Mahipal?
There are things here. There is no epinucleus here. And in these cataracts, the posterior capsule is also very lax. And the zonules can also be very weak here. So the placing an IOL scaffold takes care of all of these problems and supports it.
Any comments, Mahipal?
No, I think that's pretty well done. The second thing which Tityal said is also there, that you could leverage from the periphery like you are doing. So he thought he can put a viscoelastic, but having a support like this is obviously much safer.
No,
Otherwise, because it's a softish cataract, it's not a very, very hard cataract from that perspective.
It's a brittle cataract, it's a firm cataract. but
One thing I
it's
want to mention here is if somebody is a junior, not experienced as Ram is, 100% use scaffold.
Yeah.
Because that will make your life very easy.
Because along with these total cataracts, the zonular weakness is also there. There's always a propensity for the posterior capsule to trample in, and you get a sudden hold on to this thing and you get a rupture. Once you have a lens in place, then it works very well. And I used to think that these are very difficult procedures, but actually once you start doing it, it seems to be very easy.
I think Ram, what you have done is you have dislocated the nucleus from the back, because back has to be empty before you put the IOL. So sometimes what people make a mistake, the nucleus is floating inside the bag only and they put the lens. That will be too much of a space distance. So you have nicely taken out the nucleus up, then put the lens inside. Because sometimes these floating nucleus can be very small also, but sometimes it can be big also. So there it is little challenging to take out. The rexus size maybe then has to be little on a, maybe 5.2 millimeter to take out that.
Oh, band फिर चले गया भाई. Oh, controls cursor is gone.
One small challenge could be in further breaking down the cataract into pieces. While the IOL will definitely keep the PC away, when the nucleus is now coming anterior, to initiate and complete your horizontal chop when the nucleus is fairly hard can be quite challenging. So an alternate to the IOL scaffold could also be putting a CTR, which can also flatten the PC and prevent the trampolining of the PC or reduce the trampolining of the PC. And that also ensures that you have adequate space for your chopping maneuvers, which sometimes reduces after your intraocular lens is in place.
अगले में नहीं आ रहा है. इसमें नहीं आ रहा है.
Yeah, good point.
Yeah,
That's a
You
very
made a
good
very
point.
good point,
Yes.
Sometimes CTR does help in these cases.
Yeah.
Especially this capsule can be very floppy, what Dr. Amara was talking about, and you can catch the capsule anytime. So there you have to be very careful. Maybe a repeated injection of viscoelastic also helps in these cases to preserve the integrity of a posterior capsule.
And let's go on to another application of IOL scaffold. This was a fairly routine cataract, a little harder cataract, and I stained the nucleus, got an adequate rexus. Go ahead, it's all running at 2x the speed. And the first one half of the heminucleus is coming out, and I thought everything is under control. It looks a little jumpy because it's double the speed. Now, as I reach out to my second half, then I find that there is a fairly large rent over there. But the good thing is that still I assume the vitreous is not there, there's no distortion. So what I do is to bring that nucleus piece inside, and now dispersive viscoelastic is going behind that to create a space for the intraocular lens to go in. Here, of course, there's a fairly large rent, and I'm going to be putting a 3-piece lens in the sulcus. The initial plan was for a single-piece lens, so the incision was 2.4 millimeters. Since I'm going to shift to a 3-piece lens, I'm slightly enlarging it to 2.8 millimeters, and subsequently this is the 3-piece lens that's going in. And if there is vitreous loss and the vitreous is presenting at the wound, I would rather not do this. A mixture of vitreous, lens material and lens maneuvers is not a good idea. But in this case, I cannot be sure there's no vitreous, but then there's not significant disturbance. And now that I place the lens inside, the propensity for the large bit of nucleus, heminucleus to drop inside is going to be arrested. Even though it's anterior chamber phacoemulsification, it's edited video, I use adequate amounts of dispersive viscoelastic to protect the cornea. Go ahead with the subsequent, as you can see, the nucleus comes out very fast. And now, obviously, I have to, with a bimanual method, I go in with the irrigation cannula, and through the main port, normally you go through the side port for the vitrectomy, with the vitrector goes through that. But in this case, because I have to go sub-incisionally, I'm going through the main port, behind the lens which is there, and then going ahead and removing the vitreous. And obviously, there are some strands of vitreous still there. It's always a good idea to stain with Ramsloan acetate to make sure that the entire anterior chamber is bereft of vitreous. And of course, these cases, it's always a good idea to have a good retinal examination done about 5 days to a week later, as soon as the cornea is clear enough for a good view. Because in spite of all that you might be doing, there could be significant amount of lens matter that is there. But what I found is that I had my own hesitation about adapting this scaffolding. But now that I have started doing this, whenever there is I have to protect the PC, I go ahead and use this technique, and it works very well. Comments?
Ram, just one, sorry.
Yeah.
Sorry. The only thing is that supposing you are not able to visualize whether there is how much vitreous is there, and you don't know where the sulcus is, and in case you feel the pupil is coming down, you could even put the single piece in the anterior chamber with the haptic on the iris itself, and then on top of it, get the nucleus on top of it and eat up the nucleus, and then go back and do vitrectomy, then visualize the rexus margin, and then you can position it. Here it was more clear, so he could place the 3-piece right away in the sulcus.
Just one comment, Ram, if you see that slightly forward, if you go, when you're doing the IA portion, so all of you just see, you have in the left hand, he's got a cannula which is in his hand, which is very good. My suggestion is if you shift to a trocar AC maintainer and fix it, your left hand becomes free. So you can use the Alcon 25 gauge, which is blue in color, and you go from the limbus, slightly ½ millimeter from the limbus, but you're going above the iris, like in pars plana. And these are trocars, AC maintainer. So when you pull it out, it just automatically seals by itself. So just a small thing to tell you all, so that your left hand doesn't get restricted and it's totally free. You have fluid continuously flowing inside the eye.
Good tip. So you will always have a trocar in these situations?
Yeah, I always fix a trocar AC maintainer, because once it's fixed, it's permanently there. Just like a retina trocar, but I'm not going below the iris, I'm going above the iris.
Yes, Rohit, you wanted to say something?
I just wanted to ask, you were saying that you would be putting the single piece?
No, 3-piece.
3-piece, okay.
3-piece only.
Yeah,
oh, sorry.
So let's shift gears a little bit. This is a multifocal PMMA IOL reposition after 25 years. Actually, this is one of the first multifocal intraocular lenses that I implanted way back in 1999. The single-piece Pharmacia multifocal lens with it's a all PMMA lens, and it's basically it had served the patient quite well. It appears that I have had a PC rent at that time. Maybe we're not too wary about that. And he had a minor trauma. It got displaced, and then he presented with, you can see that the lens is subluxated, and there was loss of vision. So basically, it was a single-piece lens. The idea was, I felt the capsular rexus is intact, so I decided to see what I could do, whether I could salvage this situation. Any suggestions? What would you like to do in this?
I have fixed these cases. See, it's not it's like a single piece, but actually it's like a 3-piece. So it's a 3-piece, actually. It's not a single piece. So these cases, you can do beautifully glue them. If you glue them, you will be bang on track. You can do optic capture or reverse optic capture, whatever you want. The advantage in the glued IOL is, these are multifocal IOLs. So when you tuck, untuck, you can keep on tucking, untucking till you know you're bang centered on the Purkinje image, bang on track. So that's one big advantage of it. So my preference in such cases, and I've done a lot of such cases with glued IOL, multifocal glued IOL you can create with a very good result.
This is a pure PMMA haptics. So
no. This is PVDF.
Yes.
This is the
this
one.
Is a
see, you can see the
I think
knuckle.
this is a silicone lens foldable with PVDF haptic.
This is PVDF, exactly the one like how Zeiss guys have, no? The one which they're using in Germany.
I've used those lenses that came later. This was even before that.
Yes, I know. I've used this lens.
Yeah.
And
Ram, that was actually 3M that came up with the PMMA.
PMMA all.
Yeah, all PMMA.
You can
lens.
glue this, Ram.
Okay. Yeah. Let's see the various ways to skin the cat. I mean, this is what I am doing. So there is enough amount of rexus support over there, and this is gymnastics. I'm trying to get the lens out into the anterior chamber, so that they're using 2 Sinskey hooks, and I thought there was an adequate vitrectomy was already done 25 years back, but obviously I was not so meticulous at that point of time. So now that I've got the lens secured, slowly I dial it into the rexis, in front of the rexis, and you can see over there that it goes in there, and there seems to be adequate support, and I create an optic capture also. I do agree with Amar's point about glued IOL, but I think if you create a good optic capture in a 6mm lens like that, again invariably these lenses get well centered. There is a blob of vitreous over there. I'm using triamcinolone acetate, and you can see over here, of course the Purkinje image you might say is not exactly corresponding, but as you can see here there is a good optic capture, lens is quite stable and it served the patient quite well. Any comments?
Just one extra comment I'll also just add to this. You can do, if someone was doing, if it was a 3-piece and someone was doing a Yamane, the problem in Yamane, you have a bulb on either end, which is very good. The problem is you can't center this exactly in a multifocal the way you want it, like in a glued IOL. In a glued IOL, the advantage is you can tuck, untuck, keep on doing that till you want it bang on track. The tilt will, so you mentioned that.
Tilt is also, less with glued, because with Yamane, because you cannot really, because you go across the conjunctiva, you are not sure where you are.
Do you mean to say even if there is a good capsular rexis support there, a 5mm round rexis support there, you will go ahead and prefer a glued IOL rather than placing the lens in the...
No, this is perfectly fine. We were just discussing.
Because it's a multifocal.
Yeah.
Otherwise, 100% I'll stick to what you're doing only.
See, one thing is that this is not a lens for the sulcus, for the bag. These were the lenses for the sulcus. So basically, they were in the bag, but they are bigger lenses, and the haptics are much larger. So that's why if you put it on the capsular bag, it won't cause a lot of problem. It's an
and there is a
done thing.
good capture, and this lenses remains. This surgery did about a year back. The patient regained good vision also.
But,
This is just to show you what was there preoperatively. At the end of the surgery, as you can see, it was taken almost 9 months after the surgery, certain amount of capsular opacification happening, but still the lens is quite stable. Yes,
But what I think, these are PVDF haptic, may not be suitable for a, transscleral haptic fixation, because these haptic orientation totally different. Like you have that these, 3-piece lenses are different, Their fixation is very stable. So that's a little concern on taking this lens as a fixation,
Point taken. Let's go on to something else, a hard white cataract with rexis runoff. Shresh, maybe you can comment on this. Basically, what I was proceeding with a intumescent cataract, white cataract. As you can see here, there seems to be a tendency for the rexis to run off in this place. And what I did was to go ahead and filled it with viscoelastic, then went through the side port, used micro-rexis forceps, and then subsequently rounded it off. I thought I had an intact rexis, and I had salvaged the case. I could proceed with the rest of the case as usual. I think this is the mistake I made, in the sense that intumescent white cataract like this doesn't really require a hydrodissection. In the sense the sister just routinely passed on the hydrodissection cannula. I went ahead and injected not too much, but just a small block. But even that was good enough for me for the rexis to run off. There's already an area of weakness. It was not as if it was continuous, but there was a little curve over here, and that seems to have given way. And I have a total cataract over here, and reasonably hard cataract, and a rexis run off right in the subincisional area. How do you manage this, Shresh?
I think probably the increase in the intralenticular pressure is what led to the runoff, rather than the fact that there was a weak point. It could have happened anywhere, but possibly at the area of maximum pressure and some weakness there, it led to the runoff. But if you had to have a runoff and wanted to continue with phaco, this would possibly be the most preferred site, because now your phaco probe is going to go over that, and any chopping maneuver which is going to happen opposite to the end of the point of weakness. So generally in these kind of things, I would prefer a horizontal chop, because the forces are more centripetal. There's not as much downward force as you would have in a vertical chop. And that's generally a little more preferred when you have a runoff like this. And then subsequently, with all your chopping maneuvers, it's all, as you can see in the video, is directed away from the point of weakness, and generally you don't have the extension. Of course, you have the flutter sign also, which has been described by Rohit sir, and that can also be a useful adjunct. But very often I find my heart fluttering when I don't see it flutter, so I stop looking at it and I continue with my chopping.
Yes, Rohit, you are the master here.
No. I think Dr. Shreyas has been spot on. Basically, a horizontal chop is what should be the preferred one, no vertical chop whatsoever. The separational forces should not extend right to the sub-incisional part. The way you did it, you were knowingly or unknowingly meticulous about it, because the separational forces were quite away from that part where the rexes had run away. So that was one part, and you were using low fluidics to your advantage. That was another important thing. And you were debulking it, making it supracapsular for that matter. So I think you were covering up everything nicely.
Any other comments? Supposing it was more a beginner surgeon, do you think this is a stage to convert to a SICS or something, or you think what are the chances of the rexis runoff of wrapping around the equator?
Yeah, with the hard cataracts, with a novice surgeon, yes, conversion is a good option, because things, and a novice surgeon may not have an access to low fluidics also. So for a novice surgeon, all these things should create a situation where conversion should be one of the options.
And this is a situation where you would like to do many things supracapsular. The initial chop, of course, had to be in the bag, but once I have that fragment, I try to bring out everything into the anterior chamber, then do the classical horizontal chop, sub-chop them, and then remove them. Of course, filling with that's dispersive viscoelastic that's going in, then a blob of HPMC. I always like this idea. I want the dispersive viscoelastic to be coating the endothelium, but at the same time, if you generate too much phaco energy in dispersive viscoelastic, that's one situation where you can have a phaco burn. So I like to have a central pool of HPMC where essentially the phaco action takes place, and that gives me the control as well as the protection of the endothelium. And that's otherwise I think.
Just one point I like to add into this. Whenever you have this situation where your capsule rexus is not appropriate and you have a peripheral extension, whenever you come out from the anterior chamber, never let your anterior chamber collapse suddenly. So when you come out, you have to remove your second hand first, inject dispersive viscoelastic, maintain the anterior chamber pressure, then your phaco handpiece should come out. Otherwise, towards the end of a surgery, you have done a good emulsification, and that is the time your extension might happen. So that care has to be taken.
I think absolutely spot on.
If you want to convert it, if it's a very dense cataract and the pupil is also going down, if you want to convert it into an SICS wound, would you prefer to make it a temporal SICS, or would you change the location, suture and go to a superior?
So normally for SICS, I'm not an SICS surgeon, but I've done a lot of extracapsular surgeries. Yes. I think it's not a good idea to do a temporal large incision surgery per se. Given option, I might put one suture there and shift to a superior side, make a proper SICS incision and take out the nucleus, so that you can maintain better, rather than enlarging this incision and creating more problems.
Great. So we go on to management of posterior polar cataract. You might think that not much has changed, and this is the routine concepts that we have always been taught, and that's what we practice. That is mechanical delamination, no hydrodissection, no nucleus rotation, only hydrodelineation. I am delaminating, and that's I hit the endonucleus, hydrodelamination, and then subsequently just removing the central core of the nucleus. Create a smaller rexus because you might have to create an optic capture, and then avoid PC polishing because the PC can give way. And always explain to the patient it's a guarded prognosis. But once you do not do hydrodissection, then oftentimes the endonucleus and the epinucleus does not separate. The surgery becomes less controlled and a little more cumbersome. But most often we do get away with it, and we are able to manage it. and the incidence of 33% PCR and all that was earlier reported is not acceptable today, and it is much less. As we all know, PCR can occur in so many other, so many ways, but the posterior capsular cataract, but I think AIOS2025 has shown us that these are the different ways in which it can be presenting. Would anyone like to comment on this? Yes.
Want
Go
to
ahead.
talk? No, it's important to do an AIOS2025. That's what we do in our center. At any polar cataract, we do an AIOS2025. And if the PC is intact, we actually have started doing a hydro, not just a hydro delamination, a proper hydro procedure, but yes, a careful for surgery with control parameters and all that. And if there is outpouching as blatant as in this, even if there is a little outpouching as in the second case and a little more, then also you be careful. It should be a clear PC and a polar cataract. Then we go ahead and do the hydro procedure rotation, and you come out safe in all situations.
See, basically, I would wish to re-emphasize the role of A, slit lamp examination, B, the OCT, even the IOL Master 700, that can also give you a similar picture as regards the discontinuity. So a lot of times, obviously, we have to be careful whenever there is a posterior polar cataract, but you can pre-diagnose, and specifically if you are doing a femto procedure, the in vivo OCT that you get, that also can pick up. So as the predictive value, what Dr. Ram has written on the top, you can actually know whether, like, there's no way that the right one extreme, the third one, will not have a pre-existing rent. The idea there is to delaminate these and to actually go above this area. And at least for those who have a femto, I would push the patient, whatever it may take, to go towards a femto, because you will have a similar image that you will have here on the femto, and then you up the default so that the nucleotomy is only in that particular area where, so we would say that this is creating like a air cushion or a cushion bag like you have in your car. If you have meet with an accident, you just have that cushion coming in. So you have to maintain this cushion, and it's only then again what slow motion phaco, etc., and then also the epinucleus that you are trying, you don't peel it towards the center till the end, because once you come towards the center, it's going to give way. So you just need to bring it out towards the mid periphery, take it one after the other, and always keep the chamber filled with viscoelastic or fluid. Don't take away both your hands out, because that's going to, at times, and sometimes even a forceful hydro at the end of the procedure, hydration of the wound can even blow up the capsule. So you need to be careful right till the end.
I think all points well made. The point I want to make is when the PC is intact like this, the way we handle the cases in our institute in the last 8 or 9 months is almost like a routine cataract. You know, when you can trace the posterior capsule behind the plaque over here, here you cannot do that, there is a doubt, and here there is obviously an outpouching, and here invariably you expect a PCRN to be there, and pre-existent PCRN. So essentially in these cases, and as I'll show you in the statistics, this is predominantly the way it presents. And as you can see here, I'm going to do it almost like a routine phaco, in spite of the fact that it's a classical posterior polar cataract, simply because I could trace you can see that hydrodissection being done, and then subsequently, I'm cognizant of the fact that the PC may be intact, but it might be very weak. So I am doing the rotation of the nucleus also, subsequently removing all the lens material, and that's the cortex being taken out. And this is the PC being polished, and then subsequently the lens being implanted. And this is, as you could see, it was no different from what I would do usually in my other cases. And this is what Dr. Mahipal was talking about. And just in case there is a posterior polar cataract element, and initially we used to make a separation of almost 800 microns from the plaque to the from the posterior capsule, but nowadays we retain at 500 microns in case we find the PC to be intact. And what we find here is that you can see again the conventional hydrodissection being done, rotation of the nucleus, which are all considered to be a strict no-no when we are earlier talking about posterior polar cataracts, and subsequently the lens material is being removed, and you can see that all my maneuvers are just like I would handle a case of a routine cataract, in spite of the fact there is a posterior polar element. And this is the lens material being removed, and that's the posterior. You can see some small opacities are there. I don't even mind polishing it because I know that the PC is intact. So subsequently the intraocular lens is implanted. Welcome Dr. Chang. Essentially we are just discussing about our management of posterior polar cataract based upon AIOS2025 findings. I was just saying that nowadays when we find an intact PC like this, then I go ahead and do a routine phacoemulsification like this, where I do not hesitate to go ahead and do a hydrodissection, go ahead and rotate the nucleus, and then subsequently, though my movements are slightly softer, so that because I am cognizant of the fact that the PC may be thin and can have a propensity to give way, but otherwise generally my steps are similar to what it will be for handling a routine cataract surgery. And this is something we have been on this PC being polished by jet of fluid, and that's the intraocular lens being placed. And my management is very similar even when I'm using a laser element. And in case I'm in this situation, what I showed you, where I'm unable to trace the posterior capsule, this is what I would do. This is a fairly formed nucleus that we have over here, and an adequate rhexis, just 5 millimeters, hitting the endonucleus, not doing a hydrodissection but just a hydrodelamination, and subsequently I'm creating enough space, and it's again at 2x speed that we are running it, and without any rotation I'm basically chopping the nucleus, and the inferior heminucleus I'm splitting them into 3 hemichops, and each of these fragments will be subsequently removed, and no rotation is happening. And once half the nucleus is out, then the stress on the posterior capsule is not there, and then subsequently I can rotate the superior heminucleus downwards, then subchop it and remove it, and then proceed with the surgery. So essentially the point I want to make is that AIOS has added a significant element of in the management of these posterior polar cataract. This is under print, and this is what we have submitted. 8-month study, 5 surgeons, 67 eyes operated, and 51 of them had, 76% had an intact PC on AIOS. In these cases, we handled them like a routine cataract. And number of eyes with the PC defect was in 16 eyes. And out of these 16 eyes, 3 eyes had PC rent during surgery because the PC was not intact. While of these 51 eyes, only 1 eye had PC rent in spite of the routine phacoemulsification being performed. So we believe that the AIOS has a high negative predictive value, in the sense that if you find the PC to be intact, you can handle it like a routine cataract surgery. But just in case you suspect PC discontinuity, even then it's possible that the PC may be intact and you could get away with a conventional surgery. Would like your inputs on this.
Oh, that's fantastic. How often do you find where you think it's intact and then you do your regular technique and it splits?
As I showed you, it's happened in one case. One.
Oh, okay.
So just in 2%.
Yeah.
So we had published this about 7-8, I think 2015 or 16. And this is when, supposing I'm doing the femto and I see that it is intact, I don't then, I tell my anesthetist not to give a block or anything like that. Otherwise, normally I'll prefer to, if it is, and it's never failed me. So what you are finding are exactly the same as we have reported, that if the OCT is showing you an intact capsule, it is intact. You don't, you can handle it like a normal one.
So this AIOS based management, they definitely added a new dimension. We find that it works very well for us. And now, primary formula for biometry. No, I think Dr. Doc Cock is also going to be joining us quite soon. And basically, as you can see here, just 0.60 degrees of against the rule astigmatism is at 170 degrees. We believe in the Barrett formula, and it's a Barrett TK toric. It's not the Barrett universal. That's our basic go-to formula, because this takes into the toric calculate. This straight away tells me whether the patient needs a toric lens or not. 0.60 diopters of astigmatism, it needs either a T2 or a T3 lens. But on the other hand, in case I have a situation where it's oblique astigmatism of 0.66, almost similar to what we saw, there's no toric lens that's needed. So essentially, earlier we used to use the universal 2 calculator. Patients used to be counseled for multifocals, torics, etc. Then subsequently, when we take them on to the optical biometer, we find that in spite of the astigmatism just being about 0.6 diopters, you need a toric intraocular lens. So basically, oftentimes I'm asked, what is your indication for a toric? What is your cutoff? This is 0.75 diopters, 1 diopter for putting in a toric intraocular lens. Basically, we don't go by the number alone. We just feed it into the calculator. We're taking into consideration the posterior corneal astigmatism. We let the calculator tell us as to what's appropriate and decide on that. So even if we are going with a small amount of astigmatism, it's the toric calculator which we resort to.
I think the other factor is this a monofocal or a multifocal or EDOF? Because with a monofocal, you really have one primary focal point, high contrast, and the effect of a little bit of residual cylinder, 0.75 even, isn't that strong. But gosh, if you have an EDOF or a multifocal, the patient in the United States is paying extra for a broader defocus curve, lower contrast, and every single point will be lower if you have more than a half diopter cylinder. So there, you really want to be aggressive and do a touch-up with a astigmatic keratotomy if you want.
Great.
We actually still use Aura. I know that it was touted to sort of be this magic box to help you with your calculation, and of course it's no better than the formulas. But where it does, we don't have the T2 in the United States. So unless they have a 1.5 predicted cylinder, we have nothing in between. And so we use the intraoperative aberrometry to measure residual cylinder after putting in a spherical EDOF or multifocal, and then touch it up there on the table with an LRI.
Welcome, Dr. Koch. Since this is your subject matter, I would like your comments on that. What the point I was making is our Barrett toric calculator is my go-to formula for all my routine for intraocular lens power calculation, because even for a small amount of astigmatism like this, it tells me that it requires a toric lens. While if it's an oblique astigmatism, there is no toric that's needed, even though the amount of astigmatism is nearly the same. Would you agree with this concept? What's your go-to formula for your IOL power calculations?
Yes, we do use the Barrett and also the Abulafia-Koch, and they actually give the same number almost always. I agree with you on that against the rule. But on that oblique astigmatism, I would love to see what the actual predicted astigmatism is, and that's a flaw in the way the program is set up. They should show that to you regardless of whether you pick a toric or not. That's one of the advantages of Zeiss's program Veracity, where no matter what the astigmatism is, it tells you what the predicted postoperative astigmatism will be. Because this kind of case frustrates me. I probably wouldn't use a toric in this kind of case, but I'd sure like to see the numbers and how it looks.
Where can you access that? Where can you?
Sorry?
No, where can you see the numbers?
They're in Veracity, the Zeiss program that amalgamates all of the data, and it shows the predicted astigmatism regardless of how much astigmatism is present. It's very useful. I had a patient who had 0.3 diopters at 30 degrees, and it told me that if I didn't put a toric in, the patient would end up with about 0.6 against the rule, and if I put a toric in, the patient would end up with about 0.4 with the rule, and it was very accurate. And I put a toric in and with a much happier result.
So exactly coming to that point, here in a situation like this where a T2 will give you 0.14 diopters of astigmatism against the rule, no flipping of the axis, and T3 will give you the same amount of astigmatism but the flipped axis. Is there any choice, or you think it doesn't make a difference?
Well, I always flip the axis to vertical if possible. I mean, the work of Hayashi has shown that the astigmatism, regardless of whether you're 50 or 80, your astigmatism goes against the rule roughly 0.3 diopters per decade. So I like to leave these patients with the rule a little bit, and that I think will serve them well for a much longer period of time.
Great. So let's go on to, this is just to tell you that just in case you don't have an optical biometer, the ASCRS and APSCRS websites also gives you this information. Now let me come to a little more challenging situation. A toric intraocular lens was what was planned in this case, and it was a routine surgery. I had done my laser rexes as well as division of the nucleus. I think everything was proceeding very smoothly, and I injected the toric intraocular lens. And as you can see, it's a very smooth injection. I don't think there was any sudden. I'm just going to repeat this just to show you that I probably didn't do anything wrong. I was actually thinking it's going to be a fairly smooth surgery, but the entire lens tilted in, and I was not willing to accept that something is wrong. I tried to position it, but then it dawned to me that there is a fairly large PC rent over there, and this lens, so you can see this lens hanging over there. Patient had already a week back undergone a toric intraocular lens implant in the other eye and had about 2.5 diopters of astigmatism. We don't have 3-piece toric intraocular lenses. How exactly would you handle this case?
Now this is a probably controversial, but if the anterior chamber is deep, so in that kind of scenario, essentially the pigment dispersion is more at the pupillary margin. So if you are able to place a single piece haptic in the sulcus in a high myopic eye, and this was a high myope, and it's not that we keep doing this off and on and off, and then if you just do an optic capture of the optic behind the sulcus and haptic in the optic in the area of PCR and the haptic in the sulcus, we actually have not had issues with these patients at all, not even an IOP spike. Of course, it is a controversial issue, but there was not even a pigment dispersion in these eyes, absolutely, and the proper vitrectomy was done, and this is just one open for discussion.
Is Dr. Chang, you wanted to say something?
Yeah, you said it was a T3?
No, it's a T5.
T5, okay. Again, so you have a couple options. You could take this out, put a 3-piece monofocal, do some astigmatic keratotomy. With an older patient, you know, you could probably get 2 diopters of correction with that, and that might be close. But here, the lens is already in there, and you know, I would just do the reverse optic capture. And in that event, you've got one haptic in. You have to sort of be careful that it's not through the rent. But if you can get it so that it's not, you haven't broken the vitreous face then, and you can get it in the right axis.
No, I have broken the vitreous face because the lens is hanging.
Okay, and so you've got vitreous prolapse then, right? All right.
So
well, you're going to have to probably clean that up first. You don't want to be positioning and monkeying around with the lens while its vitreous is wrapped around that. So you may, I'd probably take it out and do the vitrectomy and then consider reverse optic capture if you want.
But for a reverse optic capture, there has to be space in the bag. Only if, supposing it's just a small area of rent, just a
this is actually,
slit.
I'm just flipping the lens, and but in my hurry to secure the lens, I've actually reversed the lens. But it's with the vitreous there, but I had to secure the lens.
Yep.
I know it's not ideal. I brought it into the anterior chamber, and now I'm going ahead and doing an adequate anterior vitrectomy. So the lens is secure now. I'll be using Tramstone Estate also to go ahead and ensure that the vitreous is completely cleaned up. And that is tricot, both in and around, to make sure that now I'm going to flip the lens around. So inject some viscoelastic inside, dispersive viscoelastic, and then I decided to do what both Dr. Chitra and Dr. Chang suggested. That's to do a reverse optic capture. And sorry, this is an optic capture.
This
Next
is an
one
optic
is a
capture.
reverse optic capture.
For reverse optic
So,
capture,
yeah,
you need to have some
yeah,
space in the bag.
And there's just a, then subsequently the lens being pushed in, and so optic capture being done. This is not at all what the classical teaching is, because either the haptics or the single piece haptics or the optics ideally should not be in the sulcus, and there is propensity for inflammation, raise in intraocular pressure, etc. I have a Varion overlay on. This will show up towards the end, and you can see that the toric marking exactly corresponds. We put these patients, as Chitra said, on steroid drops for a longer period of time. NSAIDs are also continued for almost 3 months. We have thankfully not a large series, but a few cases where we are forced to do these things, and because 3-piece variations are not available, and this 168 degrees was what was suggested, and what we got was 168 degrees. And
So Ram, sorry.
We'll just take it up. This is, as you can see, fairly good refractive outcome, and I think Shreyash also has to go. Would you like to talk about this, Shreyash? I mean, this is a posterior polar cataract, and as you can see over here, there's a fairly large rent, and a good anterior vitrectomy is being done.
I think in this case, as compared to the previous case where the PCR edges are quite ragged, you have sufficient support in the bag here in this kind of vertical split which you typically encounter in a PPC. So it would be possible for you to position both haptics, provided the axis of implantation is perpendicular to the direction of the rent. But even if not, you can still manipulate it in such a way that the haptics are on the 2 leaflets on either side of the PCR, and you could always slightly prolapse the optic over the capsular margin so that it is resting on the capsular margin, and the risk of it rotating or falling is extremely unlikely.
So this is the difference between the 2 situations, was that in that case I did not have support in this axis, so I had to place the haptics in the sulcus and create an optic capture. Here, because of the horizontal slip in this direction from the 6 o'clock to 12 o'clock, and I have enough flaps of posterior capsule available. So basically what I am doing is to place the lens in the bag, and just to stabilize the lens I go ahead and do a reverse optic capture. Thoughts?
So Ram, the only thing is, in this particular case you didn't have the lens in. It was, you implanted the lens after the whole thing.
Yeah.
So I would prefer, you got away in the first case because the rexis was pretty small, and you could do a capture. A conservative approach on working, this is rather not stressed, or we don't use it that much in India, but the cornea is another way to actually take care of it. Dr. Chang suggested doing an LRI at that, but you can live to fight the war later by doing a laser vision correction subsequently if the patient has the botheration of the astigmatism at that time, rather than ending up with malpositioned or the axis not being where it is supposed to be. So if the lens is not in, certainly I'll tell the patient you had a PCR, I'm not put a toric lens, and then subsequently you can go back and do a touch-up with the laser vision correction.
I think that's a very reasonable approach, and But would that be the consensus in the sense that, 60 to 70% of cases, now whether multifocal or monofocal or torics quite often, and once in a while you do come across this situation of a PCR, should we completely stay away and just put a 3-piece lens, or you think these maneuvers are justified?
Well, I have a question, and I'm very interested in what you said about that approach. You said that with a deep anterior chamber, what kind of an anterior chamber depth are you talking about preoperatively that you would feel comfortable doing what you described with posterior optic capture with the haptics and the sulcus?
No, this particular patient was a high myo.
Okay.
And the anterior chamber was deep. Now, if he were a hyperope, and even if he has 2.2 or 2.3, we would be considered. We can't tell you the exact cutoff. The anterior chamber was deep in this particular patient, and it was we wouldn't have got a lens for the next couple of days, and this guy had to travel in a short time, and this was when this was done, and the patient has come for follow-ups later, 3 months, 6 months. The IOL has remained centered. Only thing, we kept him on non-steroidal anti-inflammatory drops for a longer period. So is this allowed, or is no, as an absolute no-no is what? Because I felt was in a deep AC, and if the haptic is well away from the back of the iris at the periphery and in the center of
the classical teaching is that if it's a single piece lens, it should be only in the back.
I think it
and in both these cases, I showed you one case where it is optic capture, another case where there's a reverse optic capture. Obviously, what do you feel about it? Do you think it's right to do this, or it's a strict no-no?
If I'm asked, I would say that putting the haptics in the sulcus for me is a big no. Whether the space is there or not, because long term, you never know how things are going to unfold.
The cases that have been reported where the haptics are in the sulcus have been cases uniformly that did not have optic fixation. So you do have the advantage here that this lens is incredibly stable with your posterior optic capture, and that plus the deep chamber, I can imagine getting away with it. I've seen patients with one haptic in the sulcus, and they've had some transillumination defects, where the lens is all in the bag except for one haptic. They get the transillumination defects in that area, and they kind of burns itself out. They have inflammation for a while, or did have inflammation for a while. That I picked up these patients later, and they did okay. So I think the stability may be in your favor combined with a deep chamber, as you suggest.
David, what do you say?
Well, I wouldn't do it myself.
Yeah, I think if I had an intact rexus, you have a choice of, reverse or regular optic capture. And, if I were the patient, knowing what I know, I'd choose the reverse optic capture. And that's not to say for sure you'd get into trouble the other way, but I think there's a lot more track record that way. And, those haptics they just have a really sharp edge. They're really thick. And the idea that they're somehow mobile and then they're going to kind of point up would be the concern.
No, when I did these cases, I half thought that I'm doing the wrong thing and I would have to explant these lenses. I thought, let me just try this out. We have about 8 eyes. It's not a big series, thankfully. And these patients are routinely put on NSAID drops for about 3 months. And steroids are also tapered off over a period of time. And this is what we have found. In one case, I have a 6-month follow-up, and the case almost a year's follow-up. And this is 6 weeks. The lens is quite stable with a good visual outcome. This is not something I'm recommending, but because our toric intraocular lenses are so frequently used, are there any toric 3-piece lenses available at all in the world?
No. Not that we have, except we have the advantage, as David will point out, of we could put a light adjustable lens in, and then we could do a postoperative adjustment. But of course, that happening on the table, when you haven't gotten consent from the patient, that's a big problem.
Can you put a light adjustable lens if you have a PCR?
Yes, you can do it with posterior optic capture because it's a small PMMA haptic in the sulcus.
Some people you can do a Yamane with the light adjustable lens. Right. it works. You just have to be sure it's centered even with the tilt.
Right. So let's go on to another situation, residual astigmatism post refractive multifocal intraocular lenses. I had this patient in 2003. I had done a phaco with a resume for this patient, both eyes, and in the right eye she underwent, she went off to the United States, settled there, came back and did a yak capsulotomy in 2015 in one eye. And she had about, at that time we did not have the toric version, had about -2 diopters of astigmatism left over. And now she was a strapping young lady of 31 or so, wanted something to be done about it. And this was the astigmatism 2.25 in one eye, -2 in the other eye, both at the age of around 10 for a developmental cataract. I'd put in a resume lens. At that time they were quite okay to wear these glasses, but she wanted something to be done about it. What is yours? And the most important thing is that obviously the laser vision correction would be the procedure of choice. But as you can see, the total biomechanical index is very much in the red. One, the same way in the other eye also. So basically, there was a bit of a risk in doing a corneal procedure. So any choices here?
How old is the patient and how thick is the cornea?
31, and the cornea is almost some 530 or something like that. Cornea was not the, I won't really remember the corneal thickness, because you can see I am talking about the, the CBI as well as the TBI being, especially
Right.
the TBI is beyond 0.5, generally we stay away. And in spite of the patient being 31 years old, I'm a little wary of doing this, laser vision correction.
Well, you have the advantage here of having access to add-on lenses.
Yeah.
And that seems like might be a reasonable choice for someone like that. We in the States don't have that.
So that's exactly what I did, in the sense that, that's you can see the old resume lens that has been put about 20 years back. And it's not the, I'm separating the iris from the from the capsular bag, and that's just creating a space over there, some viscoelastic being injected into this potential space, and then the add-on lens is being injected. It's a Indian add-on lens that we have here, quite cost effective, and it takes care of the astigmatism, and it's a closed loop 4-loop haptics, and that's you can see the toric markings over there. Both eyes were done 3 days apart, and she had to travel back also. That's the lens going in, and you can see that you don't see that there is some problem with the syncing of the microscope on the Varion display, but it's based upon the digital overlay that these lenses are being positioned, and that's why you don't see a toric marking over there, but you can see the toric marks on the lens. That's end of surgery, very simple, quick surgery, and you can see this is the results that we could achieve. The sense that 6.6 plano refractive error. Of course, she was just 31, so no question of presbyopia. More importantly, the comments by optometrist, the patient is very happy about the visual acuity, and she went back, and she was to come back for a follow-up a year later.
What is the material that lens is made? Is it hydrophilic?
It's a hydrophilic.
Yeah, that's interesting. With those big round haptics, it probably doesn't rotate because they add, the add-on lenses from Rayner sometimes would rotate. This is made in India, you said.
It's made in India.
Yeah,
Which
that's
one is it?
interesting.
From who all make it?
This lens is made by AIOS2025. So when you have an issue like this, even for a small degree of refractive error, if Dr. Chang, maybe you could comment as the surgery goes along. I mean, it's a hard brown nuclear cataract. What am I doing right and what am I doing wrong?
Well, the dye is important because not only does it assure a nice visibility for the capsulotomy, but you'll have better visibility with your chopper, your phaco tip in terms of the capsular edge. And you're clearly making a very wide capsulotomy, which, if you're skilled enough to do that, will help. So good sign. The zonules look to be pretty good. And you're using probably a dispersive, and then
This is what I do. It's a modified soft shell in the sense that I have a coating of dispersive, and then I use HPMC in the middle so that this is not thermogenic. And
got it. And then it holds it in. Great. So this is your direct chop with a vertical chopper, and sometimes it helps to not only get really deep with that purchase, but you lift a little bit with the phaco tip as you're descending a little bit with the chopper, and then you've got a high vacuum in excess of 500. That's giving you that good grip that lets you pry those apart, and nicely done. The good purchase every time, high vacuum, you're getting a really good grip. And like you, I kind of do all the chops in situ if I can, because you get the sort of the interlocking puzzle piece effect where things are stabilized. You're going to put in a little more viscoelastic now because what's been put in is, you're replenishing it. This is the opposite of the Osher slow motion.
no, it's running at double the speed.
I'm kidding. But seriously, that is the time, not for the video, but that is the time to go slower, because we tend to relax and floor it, and that's when the pieces fly up and hit the endothelium. Yeah, very nice. And at some point, a lot of people, Roger Steiner actually popularized, when you get that last piece, going back with some dispersive retentive viscoelastic underneath it as you remove that last one there. I'm still waiting for something to go wrong.
I won't show it if it was. Anything you would have done differently, your phaco settings or...
No, the hydroimplantation which was done in your case. Would you suggest a hydroimplantation in any particular case where you would not advise a hydroimplantation?
You mean the hydrodissection?
Where he has, while implanting the lens, he has not injected viscoelastic in the back.
Okay.
Just with the infusion on, he has implanted the lens.
All right.
This is
I don't have a lot of experience with that, but you just have a tight incision, and then you're using the spatula to keep things from bouncing up. And I think if the incision's tight, you just have to be ready to put it in, because sometimes you're going to engage the capsule, there's a leak or something like that. So
I think there are a lot of Indian surgeons shifting on to the hydro implantation, and it works quite well. And yes,
yeah, I think what I do, since you asked what I do, so in my practice in hard cataracts or white cataracts, wherever I cannot see the posterior capsule, I don't, in these very hard, I don't try to rotate them very vigorously to start with before I start the emulsification. Secondly, my...
valid point, because you think there could be a posterior polar element.
Yeah, absolutely. So, so I'm slightly, more bothered that I'm not over vigorous in rotating before I start the emulsification. The second thing which I usually do is that I take out one nuclear fragment, so that this creates, after totally, when I'm separating them, I go on moving it and try to separate them. The moment I'm able to separate one nuclear fragment, that gives me a space to work around, because of the increased anterior-posterior diameter, the bag is already, overfilled with the hard nuclear mass. And I take care of the corneal endothelium also, in the sense that I use chopper as a shield. I place the chopper interiorly to the nuclear fragment so that it doesn't bounce off and touch the corneal endothelium. Lately, what I have started doing is I've started doing stratified phacoemulsification, in which I separate the hard nucleus from the epinucleus, so that it allows me to work to emulsify at a deeper plane. So these are the different things which I'm doing, because refractive surgery, cataract surgery has become refractive surgery. But the most important thing is that in these hard cataracts, they want wow factor also. And the challenge is to give wow factor in these brunescent cataracts. So we have to use, deeper plane emulsification, as Vasavda has taught, viscodispersive again and again. So, all these things, making very small nuclear fragments.
Agree with all the points. Let's just go on to this is a little harder cataract. It's
You had something to add, Dr. Paul?
Well, the only thing I mean, he can't say anything, but that was beautiful surgery. But what I actually do, I like stop and chop for these dense lenses because I like to,
maybe you can comment on this.
Okay, good.
Stop
Yeah.
and chop.
Yeah. Because I like to debulk and get rid of a lot of the hard material when I'm assured that it's in the posterior chamber. And I agree that I like to use a chopper on top when I get to the fragments, but sometimes you can't even crack these lenses really very easily, even with a chopper and your phaco tip. And I will sometimes take the phaco tip out and put a Sinskey hook in a second instrument and just mechanically peel it apart if that posterior plate will not separate. And that just, it's a very gentle way of assuring.
I'm going to do exactly what you said.
Oh, okay.
You taught me this.
I did? Yeah, see, that's so controlled and so gentle, and you can just see where it peels apart. That's a textbook example of how that works. And now you know you have two heminuclei that you really have much better control of once you finish that crack. And I like the way you rotated it and assured that you have. And now you can do whatever you want. You can take each half or chop it, but now you have that sort of assurance that you've got the pieces in a much more manageable size. Sometimes it feels like you're in the eye for all day long with these lenses.
Look at the CD, it's about 33, but I got the lens inside.
Yeah.
I think there's another trick which David was also saying, that when you hold it, you lift it slightly. So that's the trick in it. And I go right near the rexus margin, around the mid periphery, lift it, and then I use a pointed chopper, 1.75, because that doesn't displace it. It just incises it. And when I'm chopping it, I don't do it fast. What I've realized, that if you move it slowly towards the chopper, towards the phaco tip, it separates it in a better way. And if you make it fast, somehow, you try it out, you do it your routine speed, and you do it slightly slowly, and you will find that it separates more. Maybe because you are, trying to tell the tissues that you separate, something like that. David,
Yeah, I think that's a really subtle but good point. And it's almost, I find when you're with a sharp vertical chopper, you have to chop and then just wait a little bit. And it's, you just imagine you're propagating that fracture a little more with that pressure. And then you just start slowly,
that's a very important click.
Yeah.
And also the concept of multi-level chopping, in the sense that you keep a hold on the nucleus very firmly, but go level by level, so that ultimately the point is to split the backbone of the nucleus. As far as you have divided this and it has propagated through and through.
I think we have to realize that these black hard cataracts have a large anterior-posterior thickness. So at times, we don't go adequately deep, because the idea is to grip it firmly. Because when you're chopping it, there should not be any wobbling. And when we are trying to do it initially, we don't go, fully deep.
That is the reason I always create a mini trench from the sub-incisional area to the center. And that gives me a hold on to the center. Another thing is, for this I use only longitudinal phaco. Switch off the torsional comes on only when...
Absolutely, correct. Yeah.
Would you agree with that, Dr. Chan?
No, I like that.
So anyway, so multifocus post laser vision correction, I think we discussed about this in the morning also after the presidential lectures. And this was a patient I had done LASIK treatment in 1999. And you know, at that time, we had just a TMS2 topographer, a simple straightforward power, minus 2.5 with minus 0.75. And she did well. It was a microkeratome LASIK and it was a gentleman, and he was very happy with the outcome. But then he developed nuclear cataract and came up with power coming back. He was very keen on spectacle independence. Right now, when he came to us for surgery again, he was around 53. And basically we counseled him against it, but then he said that the pros and cons, we'll hear about it from our esteemed panel also. Basically the formula that I used was the Barrett 2K toric. This is, I feel, is a go-to formula when you want to put a toric intraocular lens in a post-refractive surgery eye. And invariably I find that it gives reasonably good results. And it's extremely important to make sure that it's a small power that has been treated. Post-operatively, the patient was very happy, had good visual outcome. And then you can see a sea of green over here, which means it's a fairly regular cornea. And the eye test tells me that the amount of higher order aberrations is also not much. The coma is quite minimal. So I went ahead and implanted a continuous range of vision toric intraocular lens in one eye because that has significant astigmatism. 2 weeks later, just implanted a non-toric version of the same lens, and this is what I got post-operatively. It's not, obviously we can keep discussing as to whether it's right or wrong. I think we talked about it in the morning also. I would appreciate your inputs. Chitra, you can go first.
This was a patient who had a low myopia initially. So, and these are patients where you can safely go ahead and do, was it a clear lens or an early lens?
No, it's a cataract.
He had a cataract. So cataract. So you go ahead and do a cataract surgery and do it. Even if he were a high myope, if the cataract is there, there is no question at all. We would of course try our best to do a good peripheral examination and do a laser barrage if it is indicated, and go ahead and do the cataract surgery. And Barrett 2K toric is just the way to go. At least 80% of these patients would be within plus minus 0.5 diopter of the target refraction. And the topography has to be centered, and there should be no irregular astigmatism in the central optic zone. And the patient, if he tells you that post-LASIK he did not have any night vision problems, those are some reassuring facts which can encourage you to plan a premium IOL as was placed in this situation. Of course, the dry eye status issues also have to be looked into.
We don't have light adjustable lenses. So,
what when you said a CRV, continuous range of vision, what lens was it?
Synergy. Synergy.
Oh, the Synergy. Yeah, okay. Well, that's courageous to put a Synergy in a post-LASIK eye, because the Synergy is very particular to being to the accuracy of the refractive outcome. If you're off a little bit, patients will often complain. But I do agree that the topography looks quite uniform and with a low correction. I usually, you know, I'm sounding like David Chang, but I usually do light adjustable lenses in these patients now. But this is interesting. This kind of patient would be interesting also with the new J&J Pure C. It'd be interesting how they do because of the absence of diffractive rings and the continuous curvature.
Or maybe an EDOF toric if he is acceptable to
but
have.
What about the Odyssey? Do you think that will work better?
Odyssey is the new AMO lens which is coming.
Well, it has a larger landing zone.
Yeah.
Yes, so an Odyssey might actually work better because of that. In the U.S., the Synergy has been pulled from the market and replaced completely by the Odyssey. Interesting, Jane. And they can't make enough Odyssey lenses to keep up with the demand. They're selling so well.
What is your preferred biometric formula in LVC patients?
Oh, I think the Barrett TrueK is as good as any.
With TK or
2K TK.
TrueK, yeah, TrueK TK. I think that's as good as any that are out there. There are some other really good ones, I think, that are emerging. The Evo we found to be very good. The Evo post-LASIK. I think the Pearl DGS looks promising. There's a...
Which one is it?
Pearl the Damian Gottinells, and then also there's a new version of the Shamus formula that David Cook has helped to develop. It looks promising. But, you know, we look at the Barrett first and foremost.
Any comments, Dr. Chair?
Yeah, I think that this is the type of LASIK patient, you know, it was not a heavy treatment and so forth. They're not losing a lot of contrast from a multifocal cornea that you could consider it. I would tend, and there are a lot of patients that are not candidates for the LAL. The pupil may not dilate as well. They may live far away, and the travel for the adjustments is an issue. So I'll tend to do something like the Vivity, or maybe the Puracy when we get it, probably not till 2026. Because if you end up off a little bit, like a little myopic surprise, well, that's not bad. You know, the little myopia they get is better near. And you can kind of see how they are. And if you hit it and they really want more, then you could consider a multifocal in the second eye. And you have a little idea because of your calculation outcome in the first eye, whether you feel confident with doing that in the other eye. So just in general, and I spoke about this yesterday at the ISRS, I'm doing a lot of mixing a refractive EDOF in the dominant eye and a trifocal in the other. And I find that one of the biggest benefits is really just to have the patient not have to decide between rings or unable to see their cell phone. And it's been really excellent for not only in terms of the outcomes that they get, you know, you're giving them binocularity across distance and intermediate, but just we have this problem with people having trouble deciding because you have two really good choices that aren't perfect, and that's been a real change.
What are your indications for using LAL lenses?
LAL?
Yeah.
Yeah. Well, we started the LALs, the obvious ones would be LASIK, RK. The ones that weren't as obvious is, and then, you know, maybe mild keratoconus, a lot of things like, you know, maybe something is a little tricky, but the one that actually I didn't expect, which is really popular, we have a lot of patients say, I want to read without glasses. You know, I don't mind wearing glasses for the distance. Well, what does that mean? Does that mean minus 150, minus 3, minus 125? And they don't even know either, because they don't know that they might be really happy with minus 1 or a mini mono. So we'll often point out that with the light adjustable lens, we can kind of maintain as much distance, even if it's just in one eye, and yet still meet their critical need to be able to read as well as they want. And so a lot of times we'll start them off with not much myopia or even try mini mono, knowing, okay, if they really are, like we know, some people really love their minus 350, we can bring it in. So that's allowed that group to also often emerge with much better range of sight.
We don't have the light adjustable lenses, but we still have the cornea and the laser machine. So I always counsel all my patients that, you know, going in for a premium intraocular lens, a touch-up procedure may be needed 3 months, 6 months down. And even in these cases, I make sure that, you know, there's enough cornea for me to go do a PRK procedure if there's a residual cylinder or a power. Of course, because invariably there could be fallacies as far as the IOL power calculation is concerned.
So we're doing the other session.
So these are just some quick snippets that we are going to.
Yes. Thanks a lot. Thank you.
Thank you.
See that?
So
I'm in a different one.
Don't we have the,
this is
Rex's mark.
I have a course in 15 minutes.
This is just a Rexis marker. You can see, you know, you may not have access to a digital system always, and in which case you can, what I'm doing is to use a 5mm Rexis marker, and that, because of the 14% enlargement that's there with this, it corresponds to about 5.5 millimeters on the lens surface. Thank you so much, Dr. Doc. We are almost done. So this, I find it works very well, and you know, it's centered onto the Purkinje image, and then subsequently I run the rexes just within this, and in my hands I find that it's almost as good as a rexes marker that you would get with the Callisto or with a Varion. So in case you do not have it, all you have to do is to get this 5mm ring and then go ahead and use it, and you can see that works well. The other tip I want to give is this hydro polishing. You know, after the phaco is done, all you have to do is take a syringe of about 2 ml of saline and then just run it across the posterior capsule, and invariably you find that whatever little fibers, little these are all gets washed away very easily, and on the first postoperative day itself you see a much more crystal clear posterior capsule. Of course, they may not have affected the vision, but they look much better. And this is what we alluded to, hydroimplantation. I invariably keep my irrigation cannula almost halfway into the eye. This sort of stabilizes the eyeball also, and keep it closer to the cornea. And as you can see here, this is eye intraocular pressure. Most of my phaco is done at the intraocular pressure of 30, but this is the only step when the sister pumps it up to 90, because I want a deep chamber with the posterior capsule well away. And as soon as the lens is injected inside, and the IOP is immediately brought down. As you can see here, it's brought back to, as it unfolds, is brought back to 30, and then subsequently the intraocular lens is positioned and adjust the irrigation. And even for implantation of toric intraocular lenses, as in this case, it works very well. The extra effort and the thoroughness with which the viscoelastic has to be removed in these cases is not there. I know that many Indian surgeons have adapted this, and this seems to be more of a norm than the exception today. And you can see the Varion overlay showing that this lens is well positioned. I think last of my videos, this is just for, we have this trifocal diffractive piggyback lenses also. Patient who has received a monofocal intraocular lens in both eyes. Now his brother got a trifocal done. He wants something for his eyes, wants to be freedom from glasses. After, it's not something we regularly offer to all our monofocal patients. And in case they are insistent, then this is something that you can have. And this also comes with power and toricity correction also, so that you can restore these patients also to emmetropia. I think, thank you so much for joining us, and sincerely thank Professor Chang, Professor Dog, and all my other panelists, and thank you here. We have a IC also coming up from 4:45, and just in case you have in the mood to listen, I think eminent speakers like Dr. Abhay Vasavda, Dr. Titial, and all are there. Please stay back. Thank you.